thumbnail sketch on SVTs. And when I think about those tachycardias, I just start at the very top of the heart and kind of work my way down. Just the same thing with all arrhythmias, whether it's atrial or ventricular. So basic heart, 2 atria, 2 ventricles, SA node, AV node, disc bundle, right bundle branch, and the 2 left bundles. And so when I think of tachycardias, I think of, or any arrhythmia, I think of the heart in discrete areas where they can originate from. So they can come from the SA node, they can come from the atria, they can come from the His bundle, or the AV node, His bundle, or down in the ventricles. Okay, either on the His-Purkinje system or off in the myocardium somewhere. So for the supraventricular, it's just anything above the ventricles. So that includes the SA node, atrium, AV node, and the His bundle. Okay, and so when I think of these, if we just start at the SA node to begin with, if you get a tachycardia with that, that's not really an arrhythmia, it's normal sinus tachycardia for most people. There is a syndrome of inappropriate sinus tachycardia. Not well defined, don't really know the characteristics of it, but it's kind of a diagnosis of exclusion, because you want to rule out that it's not a stimulant-induced caffeine, stimulant medications, or withdrawal of medications, like withdrawals of beta blockers or other medications. Thyroid diseases, all the typical things we look at when we go for tachycardias. And if all those are negative, and it looks like it's coming from the SA node, then it's just inappropriate sinus node tachycardia. And treatment is probably, ablation didn't work very well. We found that we just kept ablating and ablating until they needed a pacemaker, and then they would sometimes have other atrial tachycardias. But more recently, the arabidine seems to work well for that. Probably better than beta blockers.
Arabidine.
Yes, remember the heart failure medication that slows heart rate?
Oh, yes, ivabradine, yeah.
Yeah, so that tends to work well for that. Coming out of the, we don't really see or know of, or we can't visualize on EKG reentrant rhythms within the SA node. But if we come down into the atrium, we can either have ectopic beats or reentrant beats. Okay, so, and I guess I should have said when I said something looks like it comes from the SA node, that all goes back to our normal vectors, just like we talk about sometimes on our QRS complexes. So remember on our, when we look at QRS or P-wave access, I always look at lead 1 and lead ABF, which are positive going right to left, because in a normal heart, the signal, whether it's in the atrium or the ventricle, moves from the top right and over left. So in lead 1, it should be positive if it's coming from this right corner, and in ABF, it should be positive because of that vector is coming down. So if your P waves fit that normal positive in 1, positive in ABF, then you know you're coming from up in the region of the sinus node. Okay. All right. To just counter that, if you have an atrial tachycardia that's starting down here at the floor of the atrium, then you're going to tend to be negative in AVF because the atrium is going to activate this way, away from the AVF lead. And if it's a left-sided, then as you come left-right activation, you're going to be negative in lead 1. Okay, so getting back into the atrium, we have atrial tachycardias. Well, in normal rhythms, I should say, we have the wandering atrial pacemaker, which is just different sites, ectopic foci within the atria that are generating the arrhythmia. Tends to be in the normal range if it's wandering atrial pacemaker as opposed to MAT. And you'll see multiple morphologies of P waves, and you want to see at least 3 different morphologies in one lead. So remember, if you're looking at a 12-lead EKG, it doesn't count to pick a P wave in 3 different leads because they're all going to have different shapes because we're looking from different vantage points. But if in one lead you see 3 different shapes or vectors of P waves, then that fits with a wandering atrial pacemaker if it's at a normal rate, or an MAT if it's faster than 100 beats per minute. And an MAT, because it's coming from multiple factors or multiple foci, or a WAP, both tend to be very irregular kind of rhythms. Okay, so irregular rhythms, but with a clear P wave, then that's not AFib. It can be the MAT or the wandered atrial pacemaker, depending on rate. Then once you come down so those are the automatic foci where a small pinpoint cluster of cells generates the tachycardia. And they can be suppressed with beta blockers or antiarrhythmic meds. A lot of them are, again, stimulated by stressors, so dehydration, sleep deprivation, hyperthyroidism, medications, and that sort of thing, or abrupt withdrawal of medications. For reentrant rhythms, we have atrial flutters, and we usually talk about two basic types as being a typical atrial flutter and an atypical atrial flutter. The typical atrial flutter is one that comes down the free wall of the atrium and across the floor, and where your, I'm not a good drawer, but if your IVC is coming in at the bottom here, and your valve plane is over here, and your CS is up here, it comes down it creates a little valley or an isthmus. You'll hear people talk about isthmus tachycardias and ablations. And it comes down and it goes through that little valley, and then it comes back up into the atrium and around again. And so that one can be treated again with antiarrhythmics or beta blockers to kind of slow the conduction. But if you can go into that little valley between the tricuspid valve and there's a ridge of heart muscle tissue leading up here towards the coronary sinus, and if you can complete an ablation there or from the tricuspid valve over to your IVC, because that's where it's really coming, right up in between that, then you'll block the tachycardia, and they're done. So that typical atrial flutter going in that direction always gives you that very fine sawtooth kind of P wave, with your QRSs interspersed in between. The atypical flutter can come and involve both atria, like that, or it can be entirely on the left side, or instead of being top to bottom, it can be coming forward and backward in the horizontal plane or any other plane. So typical flutter means it's coming down through this valley between the IVC and the tricuspid annulus. So you'll hear it called isthmus ablation or tricuspid cable ablations and things, and that's all just referring to that one little area right there. So those are the atrial tacks and atrial flutters. The next ones are the reentrant rhythms that involve the AV node or the atrium and the ventricle. So in the AV node, and let me clear off this board a little bit. Within that AV node, and I'm going to draw this a little bit bigger. We have sometimes multiple pathways through the AV node, and there can be a fast area of electrical conduction and a slower area of electrical conduction. So I don't know if you remember, I don't know if it was in Dubin's or some of the others, but they'll often show this diagram with a triangle here, just looking at areas of slow conduction or unidirectional block. And so what that means is, as the electrical signal comes down across the atrium and say into the AV node, if it encounters an area here where there's electrical block, refractoriness, just because tissues recover at different speeds, the signal can come down on this side of the arm, but block here. And by the time it gets around tissue over here, if this is no longer refractory, then it can go around again and complete a short circuit, okay? If this is still blocked, then it'll block and you won't have a tachycardia. So for reentrant medications, we can use medications that extend the refractory period here, that help make sure that you can't complete that circuit. Or we can sometimes improve the heart tissue there. If it's an ischemic zone, maybe in the ventricle instead of in the AV node, if we improve perfusion, coronary disease, then you'll lose that difference in conduction between the areas, and it'll improve, and then this unidirectional block will go away. Okay, so this could be a fixed permanent block like a scar, or it could be a temporary block from medications or electrolyte abnormalities and that sort of thing. Well, so in the AV node, we see this AV node reentrant tachycardia here is talking about AV-NRT, and there's defined sort of a fast pathway and a slow pathway through the AV node. So if we look at conductions there, when we're in the EP lab and we bring catheters up and we have them right over here in this region of the His bundle, we can see an atrial and then a His spike and then our ventricular spike, okay? And we can watch this, and what we'll see as we pace the heart and we bring it up to an area close to where you start to see Winky block usually, what we'll see is that this A to H can lengthen out. And when it's going down the normal or fast pathway, we see a relatively short A to His interval. But if we suddenly block in that fast pathway and we come down the slow pathway, then we see what we call a jump, where all of a sudden it takes much longer time to get from the A to the His bundle. So from the atrium here to the His bundle here, so that's time across the AV node. So if we have a fast pathway and a slow pathway, what happens in these tachycardias is that we'll get, usually it's a PAC that will set it off, and so we'll get a premature beat that comes in. It'll come down the atrium, it'll typically block in the fast pathway, come down the slow pathway, and then back up the atrium. And so what we see then as we're going into that reentrant circle here is that every time it comes down to the ventricle, it comes down the His Purkinje, and so we'll get a QRS. And then it goes up the fast pathway and back out into the atrium, and it's going from bottom to top, so we get a negative deflection P wave right after the QRS. Sometimes it can actually be right up against it and almost buried in it, depending where things are. But typically it comes down, sets off the ventricle, goes up the fast, sets off the atrium, and then back down the ventricle again. Okay? So when you have a young person, especially a woman, 20s, 30s, 40s, who describes sudden onset tachycardia, sudden onset tends to mean that it's a reentrant rhythm, as opposed to an automatic focus, which warms up more like a sinus tachycardia or an atrial tach. You want to look for that retrograde P wave right after the QRS. And cues I tell people and show up on our board exams and things are young women who tend to trigger the tachycardia if they stoop over and bend back up, or if they've, or when they're in the tachycardia, they'll feel a pressure sensation on their throat. And that's because you get this atrial activation right after the QRS. So, and remember, the electrical activation precedes mechanical contraction. So what you're really ending up with is a ventricular contraction, and while your ventricles are still in systole, your atria try to contract. But the ventricles win because they're stronger, so they've contracted, the valves are closed. When the atria try to contract, the blood can't come through a closed valve, so you get a pressure back up into the neck. And people feel that as a pressure sensation in their throat. And it can make some people feel lightheaded or dizzy because of that. Okay, so the treatments again for these are vagal maneuvers. Anything that transiently blocks the AV node will stop the tachycardia. Or we can use, so carotid sinus massage, Valsalva. We can use medications, beta blockers, calcium channel blockers that will slow conduction through here and get rid of that unidirectional block. Or antiarrhythmic drugs. Or the preferred treatment now is to bring catheters from the groin up and into that AV node, and you map out, you look for the slow and fast pathways, and you want to burn the slow pathway because during sinus rhythm, you want them to have a pretty normal PR interval. If you burn the fast pathway, then they'll have a first degree AV block, a slower conduction there. And for some reason, ablation of the fast pathway has been associated with a higher risk of complete heart block later. So we selectively ablate the slow pathway. It gives them one pathway through the AV node, and then the tachycardia is gone. Okay. So AV-NRT, young women, pressure in their throat, triggered by stooping over. look especially in like V1 tends to be a good lead for that. Yes?
George, why does stooping over seem to?
You know, I haven't found a good answer for that, but I assume it has to do with a pressure change that then affects in your carotid bodies as you're steadying over, bringing up blood pressure change, and then that affects your vagal tone, your vagal and adrenergic tone, and that's enough to shift the conduction in the AV node. Okay, so we've got inappropriate sinus tachycardias, we've got WAP and MAT, focal atrial tachycardias, which tend to be still a little bit of a ramp up, but then relatively steady. Typical and atypical atrial flutters, the AV node reentrant, and I should say it can go both ways. It can go down the fast pathway and up the slow pathway, and then your P wave tends to come out a little bit further. But most typically, it's you come down the slow pathway and backwards up the fast pathway. And then the last big one for the SVTs, just make sure that's not the EP lab calling. The last one are the accessory pathways. So WPW technically is a syndrome. If you don't have any symptoms, then it's ventricular pre-excitation. If you have the palpitations, then you have the syndrome of Wolff-Parkinson-White syndrome. And so the extra pathways tend to be along the annular rings. Okay, so between the atrium and the ventricle is sort of a thick fibrous mat where the only real connection is the bundle and then the valves. But on those valve rings, anywhere along the right side or left side can be these extra pathways. And most of the time, they're actually on the endomyocardium. But occasionally it'll be a bridging fiber on the epicardium. So for these, then, what we end up with, we'll just do it on this side, is your normal signal comes down across the atrium, and instead of coming down just the AV node, it also comes down the accessory pathway. So you get a fusion of electrical activity. And what's coming down through the AV node takes the normal His-Purkinje system. So if there's no bundle branch block, you get a nice narrow complex system. But you get a little bit of a delay in that AV node before it does that. On the accessory pathways, there's no delay like there is in the AV node. So you come immediately from the atrial tissue into the ventricle tissue. And the ventricle is activating now from an ectopic focus, just like a PVC or a ventricular tachycardia. It's originating in the ventricle off of the electrical system, which means the electrical signal moves a little slower as it moves. And as it moves slower, that means your QRS is wider. Okay? That's why PVCs and ventricular tachycardias are Y complex, because they're moving through that slow ventricular myocardium and not on that His-Purkinje system. So for a normal beat in WPW, coming down both pathways, you'll get your P wave, and right as the atrium's finishing, without any delay, you're going to go straight into a slower a QRS, upstroke. But as soon as this, so if you had complete AV block, you would end up with a wide QRS. Okay, because you're activating from off the His-Purkinje system. But what typically happens is the AV node's not blocked, and so after you get that slow initial start, then you get your normal QRS coming down the His-Purkinje system that beats out the rest of this wavefront, and you end up with a narrow complex. And so that wide sloping part is the delta wave, and that's why it's there. And depending on where that accessory pathway is, which side of the heart it is, this delta wave will be positive or negative in certain leads. And that's how we can isolate or get an idea of which side of the heart it's going to be on. Okay? So now, the tachycardias that come from this is, and I guess I should say that sometimes the AV node is very healthy and the pathway is very wimpy. And so at slower rates, or at certain rates, you may see conduction through that and have a delta wave, and at other rates, you may not have it. So delta waves can come and go. Okay. But in just the right situation with the relative refractory periods again, you can sometimes block in the AV node and come down the accessory pathway. And by the time that wavefront comes back up and hits into here, it can come backwards through the AV node and then back down your pathway again. So you end up with a macro reentrant circuit. And because every time you come around here, you're triggering the ventricle here, you're going to have a wide complex rhythm. And then the P waves will be hidden in there, but they'll be retrograde coming out this way. If you go the other way, if you come down the AV node and up the accessory pathway, then you're coming down the normal His-Purkinje across the ventricles and up, so you get a narrow complex tachycardia. Okay? So coming down the AV node, we call ORT, or orthodromic reciprocating tachycardia. And if you're going the other way, the Y complex is ART. Now, I don't expect you guys to remember all that, but just remember that in a macro reentrant tachycardia, it can be either wide or narrow, depending on which way it's going. If it's regular tachycardia, wide or narrow, you can block the AV node with a medication, beta blocker, adenosine, vagal maneuver, something like that, and you'll stop the tachycardia. The trouble with WPW is if you go into atrial fibrillation and you're conducting down the AV node and the His bundle, then depending on the relative block of the AV node, we all know in AFib it becomes very irregular because the conduction through the AV node is irregular. So that means sometimes the waves, the QRSs are going to be predominantly activated through your accessory pathway and will be wide. Sometimes they'll be predominantly activated through the normal AV node, His-Purkinje system, and they'll be narrow. And sometimes it'll be a blend of the two. So you'll have varying degrees of QRS width. And so you get a polymorphic looking kind of QRS complex in that. So if you have a rapid AFib and irregular rhythm and varying degrees of QRS width, then you have to assume it could be WPW. And those are the ones you don't want to give the adenosine or verapamil and those medications for, because you'll selectively block the AV node, but you'll still be in AFib. And sometimes these electrical pathways, unhindered like that, can conduct it at 300 or more beats per minute and induce a VFib. Okay. So regular rhythms, wide or narrow, you can give the beta blockers or adenosine. But if it's irregular with variable complexes, then you want to go back to prokineamide or amiodarone or a shock, because that will block the accessory pathway in addition to any AV node effects. Okay, the last one we didn't really talk about is AFib, but that's a 2 hours talk all by itself. So any questions so far on SVTs?
For the flutter, you drew the typical flutter morphology. What is the atypical?
The P waves can be anything, because again, depending on whether the atrial vector is coming or circuit is coming horizontally out like this at you, or up and down, or shaped this way across an area of scar, or just in the left atrium isolated, the P wave morphology can be very varied. So it just tends not to be that classic sawtooth pattern like that, like you see in the typicals. Okay. So I can't draw an atypical because it could be anything. What other questions can I answer? So when I talk about SVTs, I tell people that there are a bunch of different possibilities, because you could have it from the SA node, you could have atrial tax, atrial fib, atrial flutter, MAT, all from the atrium. You can have the typical and atypical avian RTs. We didn't talk about junctional beats, and I should talk about that real quick. And then the macro reentrant, WPWs. The junctional rhythms bother a lot of people, and it's because the P waves can be almost anywhere during that. So again, if you have your big AV node here, if you have a junctional rhythm that's originating, this could be PJCs or an accelerated junctional rhythm. If you're originating from high in the AV node, you're going to exit into the atrium before you exit into the ventricle. So your P waves are going to come first. They'll be retrograde in lead 1 or lead AVF. And then you'll have your QRS complex, okay? Should be a little bit closer together. If you're originating from the bottom of the AV node, you're going to exit to the ventricle first and the atrium to the second. So you could have your QRS and then have the P wave following it. Okay, does that make sense? And if you're starting right anywhere in the middle of here, you could have a P wave that comes at the same time as your QRS, because you're going this way and that way and activating them simultaneously. And so you may not see a P wave at all. You may see just the QRSs. So when people get confused about should the P wave come before or after a QRS with junctionals, that can come at any point. Okay. Usually tightly coupled before, tightly coupled afterwards. Okay. What questions there? That was the EP lab, so we have to run. So we might have to do